Obesity is the #1 risk factor for obstructive sleep apnea. Obesity is so strongly associated with obstructive sleep apnea that compared with CPAP management, weight loss alone improved the measure of the inflammation and the insulin resistance in the patients with obstructive sleep apnea. Obesity is thought to contribute to the increased risk for the obstructive sleep apnea by compromising the airway and decreasing the lung volume. Excess fat deposits in the upper airway, including the pharynx, tongue, soft palate, and uvula, and this can lead to a narrowing of the airway, and it can promote collapsibility. Studies of individuals with a family history of obstructive sleep apnea suggest that while genetics play a role in the heritability of the disease, familial aggregation of obstructive sleep apnea is primarily driven by patterns of obesity within families. Male sex is a significant risk factor for obstructive sleep apnea, with males being twice as likely to develop obstructive sleep apnea as females. The increased prevalence of disease in males, coupled with the observations that postmenopausal women and women with PCOS are at an increased risk for obstructive sleep apnea relative to their healthy pre-menopausal counterparts, has led some to suggest that estrogen might play a protective role against the development of obstructive sleep apnea. However, experimental evidence to support the theory is lacking, and more information is needed on estrogen's role in the development of sleep apnea in women. Results of a multi-ethnic study involving 2,230 adults aged 54 years and older found individuals of Chinese and Hispanic ethnicity were at an increased risk for sleep-disordered breathing compared with white and black individuals. Additionally, Chinese individuals were 37% more likely to develop severe sleep-disordered breathing. Some of this disparity might be due to the difference in access to care, though as individuals of Chinese ethnicity were 49% less likely to receive a diagnosis of sleep apnea from their doctor compared with their white counterparts. The risk for sleep apnea increases with age. Individuals over 50 years of age are considered to be at an increased risk for obstructive sleep apnea. This may be due to factors such as diminished efficacy of the muscles and the soft tissues in the upper airway or reduced sleep quality. Individuals with anatomical abnormalities of the bony and soft tissue in the neck or the head are at a high risk for obstructive sleep apnea. Additionally, a neck circumference of greater than 40 centimeters is considered to be a risk factor for obstructive sleep apnea. In a study in over 1,900 individuals with asthma, allergic rhinitis was associated with a 1.4-fold higher odds of obstructive sleep apnea when compared with those who had asthma alone. When allergic rhinitis duration and severity was taken into account, the odds rose to almost a 2-fold. Allergic and non-allergic rhinitis is thought to increase the risk for obstructive sleep apnea by a combination of increased airway resistance due to the inflammation and a reduction in the pharyngeal diameter resulting from increased mouth breathing. Among individuals with sleep apnea, certain dietary habits have been linked to poorer quality of sleep. An analysis of multi-ethnic cohort of over 1,800 individuals found obstructive sleep apnea was associated with a lower intake of whole grains, increased consumption of processed red meat, and overall quality of life. This association was at least partially driven by the decrease in the slow wave sleep and the red meat consumption. Additionally, studies have linked later evening meals with the presence and the severity of obstructive sleep apnea. Sleep apnea often goes undiagnosed, largely because the direct symptoms are witnessed only by the bedmates, and the indirect symptoms, such as those related to sleep deprivation, can be vague or attributable to many causes. Loud or irregular snoring often indicates the presence of sleep apnea, and it's more pronounced in obstructive sleep apnea. Apneas also interrupt snoring and cause the patient to snort. Sleep apnea often causes a pause in breathing during sleep, and is noticed by another person. Someone with sleep apnea may pause breathing for a period during sleep, then gasp for air. It may be difficult to remain asleep. Patients may also awaken suddenly with shortness of breath. Poor sleep and insomnia are often the primary symptoms of central sleep apnea. Nocturia, or the frequent waking to go to the bathroom, is also common. Dry mouth, sore throat, and headache upon waking. Fatigue and excessive daytime drowsiness. Patients with sleep apnea are susceptible to falling asleep at work and while driving. Brain fog. This can include difficulty concentrating, reasoning, and paying attention. Feeling moody, depressed, or irritable. A lack of libido or sexual function. Despite the high prevalence of sleep apnea and its association with serious health conditions, obstructive sleep apnea is underdiagnosed and many patients remain untreated. Women are disproportionately underdiagnosed, despite a 2-to-1 ratio in the prevalence of sleep apnea in men versus women. Women are 70% less likely to receive treatment than men, even with evidence of sleep-disordered breathing. Therefore, simple clinical screening for obstructive sleep apnea, particularly in high-risk groups, is important. Several screening tools have been developed and validated to identify patients who are at a high risk for obstructive sleep apnea, as well as the likelihood of the clinical complications of obstructive sleep apnea in pre-surgical and hospital settings. Although screening tools are highly sensitive for the prediction of obstructive sleep apnea, they're not a replacement for formal testing. Additionally, before diagnosing sleep apnea, physicians should rule out a number of other conditions that can cause similar symptoms, including restless leg syndrome, gastroesophageal reflux disease, narcolepsy, swallowing disorder, mood disorders, or obesity hypoventilation. The definitive test for sleep apnea is an overnight polysomnography, often called a sleep study. This test has traditionally been done in clinical lab setting and monitors the occurrence of apneas, pauses in breathing, and hypneas, shallow and or slow breathing, by measuring the respiratory effort, the breathing pattern, and the blood oxygen saturation. Polysomnography also includes neurological testing to monitor limb movements, body position, and the sleep-wake state. As an alternative to lab-based polysomnography, home sleep apnea testing is now available for patients suspected of uncomplicated obstructive sleep apnea. At-home testing utilizes portable devices to measure the physiological variables, including the respiratory effort, the airflow, the heart rate, and the oxygen saturation. These devices are classified as Type 3 or Type 4 based on the number of sensors used and the variables measured. Several clinical trials have compared the efficacy of an at-home sleep apnea testing device with an in-lab polysomnography, and they've found that these test results in similar patient diagnoses, time to treatment, adherence, and outcome. In addition to making testing easier and less cumbersome, the at-home testing is associated with significantly lower patient cost compared to in-lab polysomnography. The criteria for diagnosing sleep apnea is based on the frequency of the apnea, or the hypneas per hour, that lasts greater than 10 seconds. This is known as the apnea-hypnea index. An index of 5 or greater is considered clinically definitive for a diagnosis of sleep apnea. Classification of mild, moderate, or severe sleep apnea is based on a combination of the clinical presentation and the sleep study result. Obstructive sleep apnea can also be classified based on a combination of phenotype and endotype. The phenotype of the disease represents the observable characteristic of the disease or the patient, such as obstructive sleep apnea in the elderly, men, or black patients, whereas the endotype refers to the underlying biological mechanism which drives the disease, such as fat distribution, hypo-responsive muscles on the airway, or abnormal craniofacial structure. These classifications are not based on the severity of the disease, although certain phenotypes may correlate with an increased risk for more severe disease. For more on sleep apnea, herbs, supplements, or natural treatment plans, check out my website.